Psychotherapists who are interested in depth psychology are living in a professional world that's dominated by cognitive behavioral approaches and what are called empirically validated or evidence-based therapies. And most mainstream psychologists believe that these are the gold standards of scientific psychotherapy. What I'd like to do now is tell you the other side of this story, including its shadow side, and explain why psychotherapy based on depth psychology is often a superior approach. If I had to summarize the situation at the beginning, I'd like to point out that everyone who comes to psychotherapy is suffering. And we can never fully understand human suffering using quantitative, scientific, empirical methods, because the human being is really too complicated for a simplistic empirical approach. There is a good deal of empirical evidence for the value of depth psychotherapy, but it's based on a different kind of evidence than we find in quantitative methods. A great deal of so-called scientific psychology is actually never used by students once they graduate because it becomes irrelevant to the kind of suffering that is the daily experience of the psychotherapist. Many of the problems we see in psychotherapy, much of the suffering we try to alleviate, requires a response which can only emerge from the fundamental humanity of the therapeutic couple, from an understanding of the complexities of relationships, and from an appreciation for the depths of the soul. These are very complex, uniquely individual matters, and they don't lend themselves to the application of specific laws of learning or to some other empirically derived approach that is said to apply to everyone. Human relationships are much too complicated to be fully contained in the net of empirical research. Measurement is certainly not an appropriate approach to the unconscious. The unconscious is much too slippery for quantitative methods, and it's certainly no use in the spiritual dimension, which is the dimension that Jungian psychology is concerned with. It's important to remember that all theories of psychotherapy are based on a certain view of human nature and a certain worldview. And I believe that practitioners who work within any particular approach are making a commitment to the underlying philosophy of that approach, whether or not they're doing so consciously. So it's important to understand this. Otherwise, one is unwittingly committing oneself to a view of humanity that may not be in accord with one's real values. Many approaches to psychotherapy which consider themselves to be scientific are unconsciously assuming a materialistic and a reductionist philosophy. I mean by that they assume that human behavior is nothing but the result of evolution, genetic endowment, brain processes, and culture. These approaches tend to ignore other important realms, the realm of meaning, the domain of spirituality, of the intellect and artistic concerns, and self-awareness. Much empirical psychology is based on what's called scientific physicalism, the doctrine that reality is entirely based on the physical property of objects, and also on naturalism, the doctrine that science must confine itself to the study of natural causes, which excludes anything that might be called spiritual. A lot of psychology is based on positivism, which is a philosophy of science, now rather old-fashioned, that asserts that only empirical information derived from systematic observation and experiment provides valid knowledge. Positivism rejects intuitive or introspectively obtained knowledge. But this, we find, is a much too restrictive approach to human knowledge. The humanities, art, literature, religion, mythology, all teach us a great deal about the psyche, and that's what depth psychotherapy takes into account. It's also clear that our intuitions may be correct, even if they are unprovable. For example, our moral and ethical intuitions about right and wrong may be very hard to prove empirically, but we couldn't live without them. Personal meaning is very important to us, but meaning is impossible to validate empirically. It's subjective. There are many important experiences like love, which cannot be rigorously tested, even though they're very useful and important to us. There's often a gap between what we can demonstrate scientifically and what we must actually do in the therapy room in the absence of any empirical data about what would be helpful. There is no scientific answer to questions about whether to leave a marriage or change jobs, or how to deal with a major loss, or how to deal with loneliness or alienation. So when these issues arise in psychotherapy, they demand the entire person of the therapist. Everything he or she has learned about being a person from day-to-day life experience. The attempt to squeeze the practice of psychotherapy into a scientific model is sometimes a defense against the difficulty of working with severe emotional pain for which there is no obvious remediation. Painful life dilemmas produce intense suffering, and it's naive to believe that the therapist can always be helpful by using empirically validated or positivist approaches to them. We need several types of observation to understand reality. Positivists, remember, cannot prove that there are no principles beyond what we can observe, so they cannot even prove their own assertion. Bertrand Russell, the British philosopher, pointed out that if the positivists are correct, there's no end to the verification process. We'd have to keep verifying the methods we use to verify each proposition, then verify that method ad infinitum. So there are no authoritative grounds for insisting on empirical verification. Now, some psychologists believe in objectivism, the notion that people and the world in general have objective meanings, independent of the ways we think about them. So therefore, a patient in distress is distorting his perception of a single objective reality, and the therapist has to help the patient to perceive more accurately. These kind of approaches assume that there are empirical experimental methods which will lead to universal truths or laws which are value-free. But these kind of approaches are not helpful when trying to understand the complexities of personality. Some levels of personality are very hard to quantify and are simply not amenable to this kind of consideration. Think of compassion or other spiritual dimensions of the person. Positivism often ignores the issue of the subjective meaning of events to a person. Human beings try to make sense of the world. They don't just behave mechanically according to universal laws of behavior. So human behavior is often completely unpredictable. As well, a strictly empirical approach cannot decide between right and wrong, except maybe relatively or in terms of contemporary social standards. Traditional empiricism tells us that only what is observable is real, and cognitive behavioral therapy based on empiricism urges us to think rationally about the world. But our experience is that the world is both mysterious and often non-rational. Many psychotherapy training programs teach students reductive, cognitive behavioral, or biological views of the person because these are recognizably scientific. So they make an unspoken philosophical commitment that this is the best approach to the person. But in the process, these training programs gloss over some intractable philosophical problems. For example, we often hear the phrase cognitive neuroscience. There's a very long-standing problem of the relationship of mind and brain, and this problem appears to have been solved just by joining these two words together. Now, when this kind of terminology is the lingua franca of the training program, the unsuspecting student is led to believe that brain processes cause rather than correlate with mental events, or even that brain processes and mental events are synonymous. The student may not be told that this is a very controversial, even metaphysical opinion, and the question is by no means settled. The student may not be told that the conceptual problems involved, such as the nature of consciousness, rather than the question of how the brain produces consciousness, cannot be solved by empirical means. The student may not be told that the laws that govern neurological systems in the brain do not apply at the level of a person's psychology. A person's psychology has new emergent levels of complexity which are not present at the level of the brain. So the psyche requires its own approaches. This doesn't mean the brain isn't important, of course it is, but it does mean that an account of behavior and thoughts and feeling only in terms of the brain leaves out the person who has the brain. It's far more important to understand a person empathically at the human level than it is to have an explanation at the level of neurophysiology or scientifically derived laws of behavior, which are very often much too abstract to be any use in an individual case. Psychotherapists deal with human suffering, and the experience of suffering is complex and mysterious. It requires taking into account all the sources of wisdom that are part of our human heritage. We have to borrow from our religious traditions, our great poets, our writers, our historians and artists, as well as depth psychologists like Jung and Freud and that tradition. In the practice of psychotherapy, the scientific method is not the only valuable approach to the human condition. All the wisdom traditions, literature, and the humanities must not be ignored in the service of dogmatic, cultic scientism, the notion that the scientific outlook is the only valid one. The therapist must inquire deeply into the human condition, must value mystery, develop self-awareness, imagination, and compassion. These are important but difficult or impossible to measure. The student of psychotherapy may not be told that there are alternatives to the view of human nature that underpins the training program in which the student is enrolled. This is a very important situation today because increasing numbers of people are now taking their spiritual and existential problems to psychotherapists rather than to clergy. So many contemporary psychotherapists have become de facto spiritual directors in the sense that they provide a contemporary form of care of the soul. The attempt to squeeze the practice of psychotherapy into a scientific model is often a defense against the difficulties of working with severe emotional pain for which there is no obvious remedy. And I think this is one reason that many psychotherapists don't read research journals. The kind of questions that arise when dealing with suffering people are not always dealt with by researchers who are interested in generalizations and large-scale theoretical questions. Many training programs in psychotherapy teach in a way that is directed to passing standardized exams, but there may be little or no correlation between being a good psychotherapist and the ability to pass exams. Our accrediting agencies impose a regimented series of mandating courses, but without much development on the personal development of the student. As a result, some training programs turn out practitioners who have a good deal of theoretical knowledge about behavior and they can pass exams, but they're not equipped at the human level to deal with their patients. It's quite difficult to measure a student's capacity for compassion and empathy, and these are not always stressed in academic psychology departments, which stress experimentally validated approaches to emotional distress. In practice, these approaches will often fall short of helping with suffering when they are deployed by fallible human beings with poor empathic capacity and inadequate relationship to their own psychological difficulties. One cannot do psychotherapy using a paint-by-numbers approach. Many students are well-meaning, but they've never suffered serious hardships in their personal lives, so they cannot empathize with the level of pain and suffering that their patients are experiencing. The kind of experimental research carried out by graduate students in psychology may also be irrelevant to the problem of helping a suffering person. As a result, some of these practitioners appear in their training sites to be ineffective or even harmful, because they've had academic training which has paid insufficient attention to their relational ability, their emotional maturity, their self-awareness, and overall self-development. Licensing exams and the type of degree one has are no guarantee of psychotherapeutic aptitude or therapeutic intelligence, and there are wide variations in individual ability among psychotherapists with the same academic training. In psychotherapeutic practice, there are times when theory is helpful and other times when we are out on a limb with no adequate theory in sight. Then we have to improvise and feel our way along using our humanity and our own subjective judgment about what to say, and we have to live with great uncertainty. This situation can produce considerable anxiety, And that seems to be one of the reasons that students gravitate to approaches to psychotherapy that purport to be scientific, only to learn that theoretical approaches are often inadequate. The issue of evidence in cognitive behavioral evidence-based psychotherapy is the next subject that I'd like to address. Evidence-based practice has obvious value in terms of finding effective therapies, but clinical ethicists have pointed out the shadow side of this evidence-based approach. It is rigid. It leaves little room for variation from patient to patient, and it serves the corporate interest of cost containment and efficiency by standardizing care. The insurance industry uses the notion of empirical evidence basically in order to control costs. Cognitive behavioral therapy privileges quantitative and experimental approaches to suffering, but the student therapist may not be told that, like any theory, cognitive behavioral therapy is fraught with biases, with ideology, and with hidden assumptions, and all of these imply values and beliefs. For example, if we assume that a quantitative, empirical, or experimental approach to human beings is the best one, we're unconsciously adopting a positivist philosophy and an objective theory of knowledge. These are reductionist. They ignore the complexity of the person. Reductionist interpretations of human beings lead to their being treated in a very restricted manner. Sometimes when one reads the cognitive behavioral literature, one gets a very narrow sense of the person because the person is only described in terms of symptoms, feelings, behavior, thoughts. The patient is then treated as if he or she is expected to follow instructions based on a treatment protocol which may not attend to the complexity and the larger context of the person's life. Cognitive behavioral approaches see the symptom as the problem, and the therapist then doesn't need to take into account the person's ethnicity, gender, socioeconomic status, and other aspects of the person's life which are very important. People live complex lives. They have complex emotional states, and some of them are constructed by their culture and their social situation. Depression is not always the result of faulty thinking. Sometimes it's the result of being in a difficult situation. Approaches which use a fixed protocol or a manual don't encourage the patient to talk about his or her life in a broader context than the symptom, and they restrict the psychotherapist's creativity and autonomy. Now, it's often claimed that the efficacy of empirically supported therapies validates the underlying theory, but people can recover for reasons other than the reasons given by the theory which underlies the particular therapy which is being used. There's a difference between showing that a treatment works and knowing how it works. All schools of thought have their own theory of how therapeutic change occurs, but the actual process of therapeutic change is still not always clear, because there are many non-specific factors which are common to all schools of thought. These commonalities are those such as the patient and therapist characteristics, the quality of the therapeutic relationship, shared expectancy, the benefit of facing emotional pain while being supported by another human being, overcoming demoralization, providing an experience of mastery, stimulation of the patient's hope and self-healing ability. So we cannot pinpoint any single factor as responsible for change. The cognitive behavioral therapist may believe that his or her technical interventions help, but from the patient's point of view, the therapist's empathy, caring, and capacity for relationship may be even more valuable. The notion that all forms of psychotherapy are equally effective has been referred to as the dodo bird verdict from Alice in Wonderland, where the dodo bird says, "All have won and all must have prizes." The use of a specific manual to treat an emotional disorder, which is embedded in all the complexities of a person's life, tries to force psychotherapy into a medical model in which a particular medicine is effective for a particular symptom. But for the depth psychologist who takes into account the unconscious, the presenting symptom is not the main problem. The symptom is the attempt of the personality to deal with the problem. There's a deeper level of problem. Unless the patient is able to place the symptom in the larger context of his or her life, including his or her relationships, family, occupational life, spiritual life, the symptom cannot be understood at all deeply. Complex human lives cannot be reduced to small units that can be measured. If we try and do that, we lose a sense of the whole human beings. It's important to remember that culture-bound assumptions can masquerade as value neutral. White, middle-class male standards cannot be used as a standard of healthy psychological development. But some cognitive behavioral therapy assumes these kind of standards to be normative criteria, and patients should conform to them. This is a very socially conservative philosophy which risks putting the therapist into the position of promoting conformity to the social order, as if that kind of adaptation equals psychological health. However, some people are not willing or not able to adapt their behavior to the standards and values of the dominant culture. It's important that the psychotherapist not unwittingly serve the socially dominant power group rather than the individuation process of the individual who may want to swim against the tide. Liberation psychologists have long pointed out that cultural factors such as sexism and the devaluation of women have a very important role in the development of difficulties such as the borderline personality disorder. Now, a word about the question of evidence. Some kinds of evidence are needed for the practice of psychotherapy. We need to be sure we're doing something helpful. But what I'd like to do is discuss the question of what we actually mean by evidence, because evidence is a notoriously ambiguous term. The question of the nature of evidence is a long-standing discussion among philosophers of science. We're looking for ways in which we can support or discount our belief in a hypothesis. So evidence must have some bearing on the truth or falsity of a theory. The conceptual problem is to decide what counts as evidence, how to decide when data or clinical findings become evidence in favor of a particular theory, whether some kinds of evidence carry more weight than others, and if so, who decides which kinds of evidence are which. It's also important to look at the ways in which evidence is actually used in practice. We have to remember that raw data themselves are not evidence. Data has to be interpreted, and data only become evidence in the light of a pre-existing paradigm or theory or even a metaphysical framework. To a large extent, the response to the question of evidence depends on the type of problem we're trying to study. We need the right kind of evidence for the right kind of question we are asking. Some questions lend themselves more to qualitative than to quantitative approaches. The type of evidence we need within the natural sciences is different than the type of evidence we need within depth psychology. Depth psychology doesn't have the rigorous laws of the kind found in Newtonian physics. Empirically based psychology requires that evidence can be independently observed and verified. And this field has a preference for quantifiable measurements. But we need different kinds of evidence to decide that psychotherapy based on depth psychology is effective. Empirical research based on quantitative evidence is only one kind of evidence. But the depth psychologist has no reason to privilege this rather than other types of evidence. We think it's a mistake to insist that only what can be measured counts as evidence. There is evidence based on systematic observation, single case studies. These are also forms of evidence. They give us knowledge or information about the question at hand. The relationship between the psychotherapist and the patient is another important source of evidence. The practitioner's personal life experience is evidence. Clinical experience and tacit knowledge based on years of practice are all forms of evidence. These forms of evidence can be made explicit, they can be articulated, they can be debated, and they can be verified or discounted by the community of the psychotherapist's peers. Evidence from the accounts of patients who've been in this kind of psychotherapy is also important. These are qualitative forms of evidence. Now, they're often devalued by empiricists who believe that they're just anecdotal, they're just too idiosyncratic and too subject to personal bias. But in many clinical situations, that's all we have. In all cases, empirically derived research evidence has to merge with the practitioner's knowledge and with clinical experience, and not all of that is empirically based. Some researchers are interested in what works, but in this case, a lot depends on what we mean by works, and for whom it works and in what context something works. If we consider symptom removal or the treatment of a particular syndrome, such as depression, then empirical validation means showing that one form of treatment leads to a better outcome than another. But for depth psychology, the situation is more complicated. We're not just interested in changing behavior or removing symptoms. For Jungians, for example, depression is a signal from the unconscious or from the transpersonal self that something needs attention. And from this point of view, depression may lead to an important course correction in a person's life. For the depth psychologist, therapy that removes the symptom of depression without attention to the underlying message doesn't work at all. So partly based on experience with their personal psychotherapy, partly based on the qualitative evidence that I've talked about, depth psychologists believe that depth psychotherapy fosters personal development and self-understanding as well as producing symptom relief. These are, in a way, different goals. Since the effects of this therapy on the individuation process of the individual can unfold over many years and may also affect members of the person's family, when should we judge its effects? How could we find a matched control sample? If we were to apply the question of the efficacy of depth psychotherapy to studies of large populations of people who've been in this kind of therapy, we would find results, and these have been found, that apply to particular individuals, but not to others. Whether or not the results are statistically impressive for the whole population would be irrelevant to the individual for whom the therapy has been helpful. Statistically derived knowledge always has to be interpreted in terms of an individual person. What is good statistically may not be good for a particular individual, and vice versa. Remember that the managed care industry has a vested interest in controlling the type of psychotherapy it will reimburse, even though there's a good deal of evidence that different types of psychotherapy produce similar results. The implication of insisting on a specific approach is that all patients with the same diagnostic labels, such as depression, require the same treatment. This is manifestly not true, given the uniqueness of the individual and the need for therapeutic flexibility. Many people with exactly the same DSM diagnosis and the same list of symptoms may be at very different developmental levels and may have very different personality structures and need different approaches. The value of psychotherapy based on depth psychology is that it takes into account the unconscious. It takes into account the spiritual dimensions of life, complexity and mystery. The evidence that it helps is found in our greater self-understanding and deeper connection to this mystery. Thank you.